These are the modes and mechanisms of heat transfer from a patient. This is applicable to patients that are in the operating room or in the intensive care unit. Most of this information was adapted from TrueLearn, and this image was adapted from Wikipedia, an image of a bear hugger. We'll list the modes of heat transfer, the mechanisms by which they work, their relative contribution to heat loss compared to the other modes of heat transfer, a clinical example, and the mitigation strategies for each. The first is radiation. Radiation has a plurality here, 40%, the largest contributor of all these modes of heat transfer. The mechanism is emitted radiation that carries thermal energy away from the patient. One example of this is a patient that radiates heat directly from exposed skin. This is why blankets are important. So one mitigation strategy is to keep exposed skin covered as much as possible. And you can also increase the ambient temperature so that you have less of a temperature gradient so that there's less radiation going into that gradient. If the room is warmer, then the patient tends to stay warmer. The next larger contributor of mode of heat transfer is convection. The mechanism here is the circulation of fluids like ambient gases or liquids that draw thermal energy from the patient. This is similar to a convection oven that uses an ambient gas of air. It essentially just cycles warm air around the food to warm the food. In this case, you have ambient gas of cold air that's pulling heat away from the patient. This is about 30% of the heat loss for the patient by convection. One example of this is a patient exposed to circulating air in the operating room. Operating rooms tend to be cold, and if that circulating air is cold, then that will remove heat by convection. One mitigation strategy is to keep the patient dry and covered. So again, blankets are important here. If you can avoid the draft in the operating room, that also helps. You can also use a forced air warmer like a Bair Hugger. A Bair Hugger is a blanket that attaches to a machine like this that blows warm air into the blanket. That blowing warm air actually causes convection to warm the patient. That air could be set to 42 degrees, for instance, and then you're using convection to heat the patient instead of circulating air in the operating room that would cool the patient. The next mode of heat transfer is evaporation. This contributes about 15% to the patient's heat loss in the operating room. This is the thermal energy lost to the heat of vaporization of water. So when you sweat, for instance, you are having water on your skin evaporate and you lose thermal heat that way. That's a cooling mechanism for the human body, but it can also cause heat loss in the operating room or ICU. A clinical example here is serous fluid that evaporates from open and exposed incisions. If a patient has a large abdominal procedure, for instance, and they are losing water through that large wound where they have open tissue or open mucous membranes, if it's an EGD or a colonoscopy procedure, that can cause evaporation. The mitigation strategy here is to cover any open wounds or mucous membranes unless the surgery is actively taking place over that area. So if you're not using the area, if you're not using the site, if you're not using the incision and not working in there, keep it covered. These are becoming smaller contributions to the point that the last one is negligible. The next one is respiration, and respiration is sometimes categorized under convection or evaporation, depending on the textbook that you're looking at. Respiration is about 10% of heat loss. This is heat lost via the exchange of gases and metabolites with the environment. So this is what the patients do when they're breathing on their own, or the ventilator might do this for the patient if they're fully intubated and ventilated. A clinical example here is exhaled air and humidity that's lost to the circuit or scavenging system if they're attached to a ventilator, for instance. One mitigation strategy here is to add a heat and moisture exchanger to the breathing circuit. This is usually built into anesthesia machines. You can also avoid excessive fresh gas flows so that the air is kind of being recirculated in the anesthesia machine so that you don't have to constantly re-warm it. If you're reusing some of the gas, which you can do because you have a carbon dioxide scavenging system, then you'll be able to keep warm air flowing in and out of the patient's lungs. Lastly, and this is the negligible contribution to conduction. This is heat transferred from the patient via direct physical contact with a static surface. This is how a patient loses heat, but it's a very small amount of heat. And if they're, for instance, touching an unheated metal table, they might lose a little bit of heat from conduction. One way to avoid this is to just avoid direct skin contact between the patient and cool surfaces, like cool metal surfaces. It's helpful to walk through the progression of temperature changes under general anesthesia to sort of understand how these contribute in a standard procedure. Typically, we pre-warm the patient prior to induction. Ideally, you would pre-warm the patient for at least 30 minutes before induction, but that certainly doesn't always happen. If pre-warming is done, then the patient will be warm going into the procedure, and they'll have further to drop before you might see side effects or consequences of hypothermia. In phase 1 of temperature progression during general anesthesia, you have induction, where you have a decrease of 1 to 2 degrees centigrade in the first hour in unwarmed and anesthetized patients. This is primarily due to the redistribution of heat from the core of the patient's body to the cooler periphery. This is because many medicines that we use for induction and for maintenance of general anesthesia cause systemic vasodilation, which leads a lot of blood and a lot of fluid in your body to pool to the extremities, which tend to be cooler than the core of your body. Pre-warming helps this by reducing the temperature difference between your central and peripheral tissues. If your peripheral tissues tend to be warmer, if you've had a Bair Hugger on you for 30 minutes before induction, or if you've been under blankets, or if you're in a warm operating room, then the drop in temperature during systemic vasodilation will be less. Phase 2 is a gradual decrease by about 1 degree centigrade in the next 2 to 3 hours under anesthesia. This is continuous heat loss to the environment, and this is traced to the basic modes of heat transfer that we just discussed here. The dominant mode, as we said, is radiation, which is the direct emission of heat from the body to the surrounding environment, which, as we said, can account for up to 40% of temperature decrease during phase 2. Phase 3 is a stable hypothermic plateau that's reached after approximately 3 to 4 hours under general anesthesia. The core body temperatures here approach a steady state value of about 34 to 35 degrees centigrade. In this state, you have dampened thermoregulatory mechanisms, primarily vasoconstriction, that counteract additional heat loss. But again, you don't reach this phase 3 until about 3 or 4 hours under general anesthesia. I hope this overview of modes and mechanisms of heat transfer for heat loss from patient's body was helpful, and thank you for listening.